So you have already know, I think you already know that what is pneumonia. Can anyone say what is the definition of pneumonia?
Inflammation of lung parenchyma is pneumonia.
Okay. Any other definition? So what are the bacterial agent causing pneumonia?
Streptococcus pneumoniae.
Okay, any other?
Streptococcus viridans.
Okay. So today I'll be talking about the fungal and parasitic pneumonia. Okay, the causative agent, the fungus as well as the parasite, they also can cause the pneumonia. So as the respiratory tract, they have been divided into two different parts. Okay, the upper respiratory tract and the lower respiratory tract. The upper respiratory tract includes from nasal cavity to the trachea, and it includes the tonsils, the oral cavity, the larynx, as well as the sinuses and the eustachian tubes, middle ear, and the opening of the auditory tubes. So it all comes to the part of the upper respiratory tract. And the upper respiratory tract, the infections are more common and they are easy to treat and the complications are less. Whereas in the lower respiratory tract, it includes trachea, bronchus, bronchioles, pleural, and diaphragm. And also it includes the lung parenchyma. And in the lower respiratory tract, the infection of the lung parenchyma in association with the accumulation of the fluid is known as pneumonia. So the lower respiratory tract infections are less common and it is difficult to treat, and the complications are more in the cases of lower respiratory tract infection. So the pneumonia, it infects the air sacs in the one or both the lungs, and there is a presence of the fluid which is also known as pus or the purulent materials, due to which the patient complains of cough, fever, chills, and difficulty in breathing. So as in the picture, you can see the healthy alveoli and the infected alveoli. In the healthy alveoli, there is a normal alveoli in which the gas exchange takes place normally so that the patient won't have difficulty in breathing. Whereas in the infected alveoli, there is an inflammation of the alveolar wall and there is a presence of the purulent material due to the causative agent. So the air sacs, they get filled with the purulent materials, due to which the gaseous exchange is not there. The main function of the alveoli is exchange of gases. So which does not take place, due to which the patient will have difficulty in breathing. Okay. So the pathogenesis, it might be due to inhalation, aspiration, or hematogenous. So today I'll be talking about the fungal as well as the parasitic causative agent that lead for the pneumonia. There are two different forms of fungi, the mold and the yeast form. These mold and the yeast, they are widely distributed in the air, dust, fomites, and sometimes they are as a normal flora of the body. And 300 species, they are related to the disease. Okay, they are linked to the disease in animal and as well as in the humans. And fungus, they are one of the most common plant pathogen. And the human mycosis or the human infection by the fungi is mainly caused by true fungal pathogen as well as opportunistic pathogens. And the portal of entry, the pathogenesis include the portal of entry, the virulence factor. The primary mycosis is through the respiratory route. And the respiratory route is mainly due to the inhalation of the spores. Sometimes there might be subcutaneous mycosis. It means that there is an inflammation in the skin due to the fungus through the inoculated way, the inoculated route through the skin if the patient is having trauma. So if there is a trauma in the skin, then there is the inoculation of the spores through the skin, leading to subcutaneous mycosis. And also sometimes to the surface. If there is contamination of skin surface with the fungal element, then the patient might have superficial skin infection. The virulence factor, they also play a role in the pathogenesis of the fungi. Thermal dimorphism, toxin production, capsule, adhesion factor, enzymes, they all act in the pathogenesis of fungal infection. The antifungal defenses are also the integrity of the barrier as well as the respiratory cilia. And most of the defense mechanisms are the cell-mediated immunity. So coming to the fungal infection, okay, the pneumocystic carini or girovesi. It is also named as pneumocystic girovesi, which leads for pneumonia. So it is pronounced as girovesi, which is most common fungal infection, usually in the opportunistic. It is an opportunistic infection, mainly in the immunocompromised host, like in the cases of HIV patient. So it is a serious infection that is caused by fungus, which is pneumocystic girovesi. And initially there was a debate whether this is a fungus or it is a parasite. So initially it was thought to be a protozoan, but later on the biochemical analysis of the nucleic acid composition and the mitochondrial DNA, it is later named or the categorized into the fungus. So pneumocystic girovesi, it was first classified as a protozoan, but now it is considered as a fungus. And it was first described by the Charles Chagas and the Carini in 1910 in the lung of the guinea pig. And it was appeared in the human as a pathogen in the AIDS people in 1980s. And the habitat of this fungus is they are saprophytes, and they are found as well as in the extracellular parasite in the pulmonary alveoli of the healthy individuals. So they are responsible for causing opportunistic infection. And the most common cause of pneumonia in AIDS is girovesi, okay, the pneumocystic girovesi, which is difficult to treat, and it is responsible for damaging the alveolar epithelium, and it embeds the gas exchange as well as it reduces the lung compliance. First, it was named as the Carini, but nowadays it is named as a girovesi. Okay, Anjali Adhikari.
Yes, ma'am.
Okay, what is opportunistic infection?
Normally, the organism remain as a normal flora in the body. Whenever there is a immune system is decreases inside the body,
Then
these normal flora responsible for the disease.
Okay. Okay, so then coming to the morphology, okay, there are trophozoites, which is 1 to 5 micrometer in length, and it is amoeboid in shape, and it also contains the central nucleus. The cytoplasm contains mitochondria, ribosome, endoplasma, reticulum, and various granules. And the division of this trophozoite takes place by binary fission. It also contains precyst, which is 3 to 5 micrometer, oval in shape, and there is a presence of cluster of mitochondria in the center with the presence of few filopodia. This filopodia helps for the attachment as well as for the movement, and there is a presence of the nucleus where it undergoes as a 3 division. And it also contains the cyst, which is spherical in shape, which is 5 to 10 micrometer in diameter, and it is covered by the thick wall. And it contains 8 oval shaped intracystic bodies or the sporozoids. So coming to the life cycle of this parasite, okay. So this is the cyst. The cyst form is more infective form, and when the individual inhales the cyst, then there is a release of the sporozoids. And these sporozoids, some of the sporozoids, they again get converted into trophozoites, and some of the trophozoites, they divide by the binary fission. And some trophozoites, they become encysted and they produces 8 daughter trophozoid within the cyst, which is also named as intracystic bodies or the sporozoids. And these cysts, they collapse and they releases the trophozoids, which are ready to initiate the multiplication on the same host or maybe in the another host. And the transfer of to the another host is through the coughing. Okay, while coughing, they may spread the disease, and there may be the inhalation of the spores. So this is the electron microscopic picture in which you can see different forms of this parasite. Initially, it was under the protozoan, but now it is graded as a fungi. So these are the risk factor. The risk factor in the patient where there is a immunocompromised stage, which means there is a deficit in the cellular as well as the humoral immunity. And if the patient is having chemotherapy for the longer duration period, then the patient might be immunocompromised. Bone marrow or the stem cell transplantation, the solid organ transplantation, or if the patient is under the immunosuppressive treatment. And whenever, if the patient is taking prolonged corticosteroid therapy, or if the patient is having AIDS or HIV infection. And sometimes the patient born with the immunodeficiency syndrome, congenital immune deficiency syndrome. And sometimes if the patient has undergone the splenotherapy or splenectomy, which means there is a removal of the spleen. And sometimes it may be genetic, or in the cases of hyperglobulinemia syndrome, or in the cases of the premature malnourished infant. So these all are the risk factor for having fungal infection. Okay. So coming to the pathogenesis, the pneumocystosis, it is an opportunistic infection. Whenever in the healthy lung, the alveolar macrophage, they ingest and they kill the microorganism. If the individual is healthy, then the chances of infection is very less. Okay, whereas the presence of the alveolar macrophages, they ingest as well as they kill the microorganism. Whereas in the immunocompromised host, like if the patient is under chemotherapy, if the patient is under steroid therapy or splenectomy, or if they have born with the congenital immunodeficiency, or if the patient is having HIV/AIDS infection, then in those patients, the organism, they get the environment, okay, to proliferate as well as to remain extracellular within the alveolus, attaching lightly to the type 1 pneumocytes, due to which there is a damage of the alveola, resulting in the increased alveolar capillary permeability as well as the surfactant abnormality. And there is a host response, due to which there is an increase in interleukin 8, and due to which there is a foamy vascular exudate. There is a presence of macrophage, lymphocyte, and the plasma cells, due to which the long structure becomes foamy vascular. And in the severe cases, there is a honeycomb pattern, which means there is a interstitial edema, fibrosis, and there is a formation of the hyaline membrane, due to which there is a appearance of the honeycomb pattern. So once there is a inflammation as well as increased permeability in the alveolar, then the patient will present with the fever and the cough will be non-productive. So once there is involvement of alveoli, there is no any gases exchange, due to which the patient will have difficulty in breathing. The patient will have chest pain. Okay, and the patient also complain of chills, fatigue, and tachypnea. Okay, so what is tachypnea? Okay, Janvi. Janvi absent. Okay, Ranju.
Yes, ma'am.
Okay, what is tachypnea?
Tachypnea is increased breath rate.
Okay, so what is the normal breath rate?
12 to 20 breaths per minute.
12 to
20.
20, 12 to 16. Okay, and what is tachycardia?
Increased heart rate.
Increased heart rate. Okay. Okay. So once the patient will have fever, non-productive cough, difficulty in breathing, chest pain, then we go for the diagnosis. Okay. So the sample we have to collect is sputum. If the patient can cough, we can directly ask for the sputum. If not, then we have to collect the sputum through the procedure, and we can take out the bronchoalveolar lavage and then do the staining. Okay. Periodic acidic fast stain, sniff stain, or we can do the gromary methylamine stain, in which we can find the yeast-like cells, okay, which is the crushed ping pong ball-like appearance. So here in the greenish staining, you can see this is the gromary methylamine silver staining, where you can find there is a plenty of cluster of or the aggregate of the yeast-like cells, okay. And on the next picture, where you can see the apple green like color, this is the immunofluorescent. Okay, once you do the staining with the fluorescent dye, and then if you see in the fluorescent microscope, then you can find out there is a apple green like yeast cells. Okay, and you can find they are present in the given sample or the sputum sample as well as the bronchoalveolar lavage. The disadvantage of this staining is that the internal structure cannot be properly visible. Okay, so once you can do the staining, the next you can, if possible, some long biopsy, then you can find out there is a thickened alveolar septa with the fluffy eosinophilic exudate. So here you can see the eosinophilic exudate that is present in the alveoli. And you can do the serodiagnosis with the help of blood. You can separate out the serum and do the serodiagnosis, where you can detect the antigen as well as the antibody. The antibody, we can detect the anti-pneumocystic zero base antibody. This test is usually done for the epidemiological studies. And you can also do the antigen detection with the help of ELISA for the diagnosis of the pneumocystic infection. And you can do the PCR from the different sample, where you can find out the pneumocystic antigen or the DNA in the or the gene in the sample. And you can do the radiological investigation. On the chest, you can find bilateral diffuse infiltrate starting from the perihilar region of the lungs. So though it is graded as a fungus, but the infection they do not respond to the antifungal. So the treatment of choice will be trimethoprim sulfamethoxazole as a primary or as a first line of treatment, with some second line like pentamidine, dapsone, pyrimethamine, or atovaquone. You can use these drugs for the treatment for the pneumocystic Jerovesi infection. And in the cases of prophylaxis is usually given in the cases where the patient is immunocompromised. So in those patients, you can start with the trimethoprim sulfamethoxazole if the CD4 T cell will be less than 200 micrometer. If the patient is HIV positive, so in those cases, you can start with the prophylactic treatment, and in the cases of oropharyngeal candidiasis. Okay. So one is pneumocystic Jerovesi pneumonia. The other fungus that causes pneumonia is the endemic fungal pneumonia pathogen or the dimorphic fungi. The Histoplasma capsulatum, Coccidiodesmitis, Blastomyces dermatitis, Paracoccidioides brasiliensis, though these all are responsible for causing fungal pneumonia. Okay, pneumonia, and they are dimorphic. Dimorphic means due to the variation in the temperature. Like in the cases of 25 degree, they are in the mold form, whereas in the 37 degree, they are in the yeast form. Okay, so they are dimorphic depending upon the temperature variation. And certain other pathogens like Candida, Aspergillus, Mucor, Cryptococcus, and Zygomycetes, they all also cause the opportunistic fungal pneumonia. So here in the picture you can see the dimorphic form. The 25 degree, there is a mold-like form, whereas in 37, they all are in the yeast form. So these four different, they are the dimorphic fungi which are responsible for causing pneumonia. And in the opportunistic fungi, the Candida, Cryptococcus, Aspergillus, they all causes infection basically in the people who are immunocompromised host. So the Candida infection, mainly if the patient is under antibiotic therapy, catheter, diabetic, or on the steroid therapy, then they might have fungal infection due to which it may lead to the Candida that causes the pneumonia. Leukemia, corticosteroids, if the patient is having tuberculosis, so in those patients, the opportunistic fungi, they may play the role for causing pneumonia. So coming to the parasitic pneumonia, okay. Okay, Janvi, absent. Nilisha Bhandari. Apeksha Bhattrai.
Yes, ma'am.
Okay, so what are the fungal causative agent leading to pneumonia?
Pneumocystis xeroveci,
Hmm.
Histoplasma capsulatum,
Okay.
Coccidioides immitis,
Hmm.
Blastomyces dermatitis.
Hmm. Okay. Okay, Nilisha Bhandari. Okay, Saksham Bhattrai. Sanskriti. Okay, Shreya. So all are absent.
Yes, ma'am.
Okay. So what are the sign and symptom, and how do you diagnose the case of pneumocystic carini or the Jerobaceae infection?
Clinical features are fever, chest pain,
Mm,
difficulty in breathing,
okay.
tiredness,
Mm,
tachypnea,
okay. So how do you diagnose
non-productive
the case? Okay, non-productive cough. Okay. So how do you diagnose the case?
sputum and or bronchoalveolar lavage is taken.
Mm,
Staining is done.
mm,
Periodic or Gomori methanamine stain.
okay. So here you can see
In
the. Mm,
we can see crushed ping pong balls.
mm. Or you can do the immunofluorescence staining. Okay.
Yes, ma'am.
Okay. You can do chest X-ray, you can do PCR or serodiagnosis where we can detect the antigen as well as the antibody. Okay. Now coming to the parasitic pneumonia. Okay. So parasitic pneumonia are also common where the patient is immunocompromised host. Like if the patient is HIV/AIDS, infected with HIV or AIDS, or the patient is having using immunosuppressive drugs, or the patient has undergone any organ transplant. So in the cases of immunocompromised host, there is a chances of parasitic pneumonia. So these are the parasites, okay, that lead for pneumonia. The Entamoeba histolytica, Leishmania donovani, Echinococcus granulosus, Schistosoma. So these all lead for the pneumonia. Paragonimus, okay, which is also known as long fluke. This also leads for the pneumonia. And these nematodes, they causes the Loeffler's pneumonia, which like Ascaris lumbricoides, Ankylostoma duodenale, Nectar americanus, Strongyloidiasis torcoralis. Okay, so these microfilaria, these all lead for the pneumonia. So coming to the pulmonary ascariasis. So the ascariasis infection is mainly due to the contamination of the food. Okay, the contaminated hands can also lead for the in intake of the food. Okay, intake of the food. It does not causes direct infection to the lung, but through the indirect route they reach the lung and infect the lung parenchyma. So firstly, they are when we take the contaminated food, then they are intake or they goes towards the small intestine where there is a presence of the first stage larva and the molting occurs, and they are converted into second stage larva, and these second stage larva they penetrate the wall of the intestine and they travel by the portal vessels to the hepatic circulation and to the right side of the heart and reaches the lung. And this second stage larva, they molt twice time in the alveoli where they produces third as well as the fourth stage larva. And these migrating larvae, they induce granuloma formation with the eosinophil, neutrophil and presence of macrophage as well. And once they reach the, when they are inside the intestine, there all are the GI symptoms. And when it reaches the lung, if the host is immunocompetent, then sometimes it's symptomatic. The patient does not have any clinical symptoms. But in the immunocompromised host, there is a respiratory symptoms like there is a migration of the pulmonary migration and there is a airway hyperreactivity and there is a spasm of bronchioles which lead to the mild cough to the Loeffler syndrome, which means the patient will complain of high-grade fever, mucoid cough, okay, chest pain, hemoptysis, and even when you auscultate the chest, you can listen the wheeze, okay, and there might be shortness of breath. So what is hemoptysis? The presence of blood in the sputum, okay. And for the diagnosis, you can find in the chest X-ray there might be right basal consolidation and there might be effusion. And the sputum may show. So in the ELISA, you can do the serodiagnosis as well as for the treatment. There might be self-limiting disease as well as we can start with the mebendazole or albendazole. In the cases of ankylostomiasis, what is the root of infection? Okay, Shreya.
Yes, ma'am.
Okay, so what is the root of infection for ankylostoma duodenale? How does this parasite get into the body?
Skin.
Through the skin. It penetrates the skin because there is a presence of filariform larva. Okay. So ankylostoma duodenale or the nectar americanus. So the egg. These egg they are segmented ova and with the presence of 4 or maybe more blastomeres which is passed out in the feces. And the rhabditiform larva that develops from the its egg in the soil and they turn into filariform. So the rhabditiform they are non-infective form, whereas in the soil they gets developed and they form into filariform, which are infective to humans. So these infective larvae get inside our body through the skin. They penetrate the skin, they reach the pulmonary circulation through the lymphatics as well as the venules. And the larvae, they penetrate the alveolar wall and they ascend the bronchi, trachea, larynx, pharynx. And they are again swallowed to the so that they reach the upper part of the small intestine. So when they are inside the lungs, then initially at the site of entry, there might be itching or it may lead for the cutaneous larva migraines. And when they enter to the respiratory tract, then the patient will complain of bronchitis, bronchopneumonia. When these larvae, they break the pulmonary capillary, they enter the alveolar space, leading to Loeffler syndrome. And here also the patient will have fever, shortness of breath, productive cough, hemoptysis, okay? And there might be chronic loss of blood due to the as these parasites lead for the microcytic hypochromic anemia and later the patient might have cardiac failure. So for the diagnosis we can do stool microscopy where you can see the demonstration of the egg and sometimes through the duodenal aspirates. You can also find out some eggs as well as the larva form, okay? And as this parasite lead for the anemia and there will be increase in the eosinophil count. With the help of PCR also we can detect the or diagnose the disease. And in the treatment we can use mebendazole as well as the albendazole. So strongyloids they also lead for the Loeffler like syndrome, okay? The strongyloids infection mainly occur in the opportunistic host or it is an opportunistic parasite. So in some cases it might be asymptomatic, but there might be the patient might have cough, shortness of breath, wheeze, and the hemoptysis. Moreover, it may also lead for the acute anemia with acute renal failure, and there might be systemic inflammatory response syndrome. So for the treatment of the strongyloides infection, you can treat with the ivermectin, thialbendazole or albendazole. So if you see in the sputum, you can find the larva, okay, phyllariform larva, which lead for the diagnosis for the pulmonary strongyloides. Paragonimus westermanni, okay. So this is also the long fluke, which is responsible for causing pneumonia, and mainly it occurs due to the eating of the freshwater crab or the crayfish if they are not cooked properly. So these larvae, they penetrate the intestinal wall and then they migrate towards the long parenchyma. So the presentation will be like the patient will have chest pain, high grade fever, hemoptysis, chronic cough. So in this case, we can see in the feces, we can see the operculated eggs and sputum, as well as in the bronchoalveolar lavage. And as in most of the parasite infection, the eosinophil count will be high, as well as the serum IgE will also be raised. So in these cases, you can use praziquantel, and you may require surgery if there is a persistent pneumothorax, pleural effusion or empyema. In the pleural effusion, there will be presence of fluid, okay? Whereas in the empyema, there is a presence of the pus. And you can see in the radiological feature in the chest x-ray, you can see the patchy air space consolidation with the cystic changes and the presence of effusion as well as the pneumothorax, where you can find ground grass-like appearance. In the CT scan also, you can see the cystic lesion, which is filled with the fluid as well as the gas, and there might be the area of consolidation. So another parasite that lead for the pneumonia is Int amoeba histolytica. So mainly it lead for the liver abscess, and these abscess, when they are not treated on the time, then it may extend towards the lungs through the irritation of diaphragm, and it may spread the infection to the lung as well. So the patient might present with the cough, high grade fever, shortness of breath. Okay, so through the right hepatic extension, there might be direct extension towards the diaphragm of the right lobe of the lungs. So the patient might present with the shortness of breath, cough, dyspnea, chest pain. So on the radiological feature, you can find effusion as well as there is the involvement of the basal area of the lung, and there might be low lobe consolidation, and later it may lead to the lung abscess. So we can use tinidazole or metronidazole, as well as we can use the, if it is not, it is extensive, or if it is too huge, then the surgical treatment or the drainage of the pus should also be done. So these all are the parasitic cause that lead for pneumonia. Okay, Rishabh?
Yes, ma'am.
So what are the parasites that lead to the pneumonia?
Ma'am, they are pulmonary ankylostomasis.
Okay, you can tell the name.
And
Pulmonary ancylostoma duodenale. Okay.
Entamoeba histolytica,
Mm.
Leishmania donovani, and Echinococcus psychostoma.
Okay. So what is the route of entry for the Ascaris?
It is transmitted through contaminated food,
Mm.
through oral route, and it reaches intestine,
Mm.
and through portal system it reaches hepatic circulation, and then right sided of the heart, and finally to the lungs.
Okay. So once it reaches the lung, what are the clinical signs and symptoms that the patient present with?
The clinical features they are asymptomatic,
Mm.
but may occur with a mild cough,
Mm.
and there may be chest pain or dyspnea
Mm.
and hemoptysis.
Okay. 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 Arpana? Aparna? Nilisa? Okay. Sanskriti? So all are absent. Sneha? Salini? What are the other cause that lead for pneumonia? Parasitic cause? So what are the parasitic cause? Okay, Ritika? Okay, Saurya? Absent. Saksham? Saksham Bhattrai?
Yes, ma'am.
So what are the parasitic cause? Okay, Anjali?
Yes, ma'am.
So what are the parasite that causes pneumonia?
Entamoeba histolytica, Leishmania donovani,
Mm.
Paragonimus stomani,
Mm.
Trichinella spiralis,
Okay. Ankylostoma duodenale, Ascaris, okay. Entamoeba histolytica, Paragonimus westermani. So these all lead for the pneumonia. So what are the risk factor or the immunocompromised host in which the patient are more prone for fungal as well as the parasitic infection? Okay, Anjali?
A patient undergoing chemotherapy, organ transplant, steroid therapy, congenital immunological disease,
Immunological disease. Okay.
AIDS patient,
Okay. So which are the parasite that causes infection in HIV/AIDS? Okay, Ranju Adhikari.
Yes, ma'am.
Okay, what? So the parasite that causes opportunistic infection in AIDS. So what are the opportunistic infection? Which parasite causes opportunistic infection in AIDS people or the immunocompromised host?
Ma'am, Strongyloidiasis stercoralis
Okay.
and Amoeba histolytica also.
Yeah. Okay. Pneumocystic gervasi. Okay. That is also the one. Okay. Any other?
Ankylostoma
Ankylostoma?
duodenale.
No. Strongyloidiasis, pneumocystic carini. Okay. MumbaI histolytica. Okay. Any other?
Ma'am, I don't remember.
Okay. Apexia? Absent?
Yes, ma'am.
Okay. Can you say some other opportunistic infection that the parasite causes opportunistic infection? Which parasite causes opportunistic infection? One is strongyloids. Any other?
Paragonimus.
In the HIV patient, if the patient complains or if the patient have a persistent diarrhea, so which parasite causes persistent diarrhea in HIV patient?
That I don't know, ma'am. That about that.
Okay, Cryptosporidium parvum, Cyclospora, Isospora, Microsporidia, they all lead for the persistent diarrhea. Okay, especially in the patient who is suffering from HIV/AIDS. Okay, Strongyloids, Stercoralis also lead for opportunistic infection in HIV patient, giardiasis, leishmaniasis, Entamoeba histolytica, they all are opportunistic infection. Okay. Okay, Nilisa absent? Janvi? Janvi also absent, right? Ayushma?
Yes, ma'am.
What is Loeffler's syndrome? What is Loeffler syndrome? Which parasite lead for Loeffler syndrome? Other Loeffler pneumonia.
Ascaris.
Okay, Ascaris, okay. Any other? Ascaris, Ankylostoma. Okay. Pneumocystic carini, that is the fungus. Any other like Paragonimus westermani. Okay, long flukes, they all lead for Loeffler's pneumonia, strongyloids. Okay. So these all parasites which we discussed today, that all lead for Loeffler syndrome or Loeffler pneumonia. So what are the signs and symptoms of Loeffler pneumonia?
Mild cough,
Mm.
chest pain,
Mm.
dyspnea,
Mm.
fever,
Mm.
hemoptysis,
Mm.
difficulty in breathing,
Mm. Okay, tell something about pneumocystic carini. Okay, Anjali, what is pneumocystic carini pneumonia? Okay, Ranju Adhikari.
Yes, ma'am.
So what is pneumocystic carini? If there is a short note on pneumocystic carini pneumonia, so how do you explain or how do you write it?
Ma'am, it is the most common form of infections that leads to pneumonia,
Mm.
and it is caused by Pneumocystis girovisi fungus.
Mm.
Uh, and this fungus mainly cause infection in case of immunocompromised host, like the person undergoing uh, some immunocompromised immunosuppressive therapy,
Mm.
and the persons who is having congenital immunocompromised disease like HIV/AIDS, and those persons who is undergoing splenectomy.
Mm.
And this pneumocytic girovasi mainly cause infections through respiratory tract, and when it enters to lungs, then it causes damage to alveolar epithelium,
Mm.
and that leads to impairment in gaseous exchange, so patient will feel difficulty in shortness of breath.
Mm.
And this pneumocystic girovasi has three morphological form: trophozoite, precyst, and cyst.
Mm.
uh, Trophozoite size 1 to 5 micrometer in length, and it is amoeboid in shape and has a central nucleus.
Mm.
It divides by binary fission. Uh, Precyst is 3 to 5 micrometer in length, and it is oval.
Diagnosis, yes. So
And
this.
cyst consists of 8 oval-shaped intracystic body or sporozoites, which is the infectious form.
Mm.
And this cyst, whenever it enters to body, then it change into trophozoite form, and inside body it leads to it releases the sporozoites, and these sporozoites will cause infections to human.
Mm. So how do
Ma'am,
you
that
diagnose this case? So
for the
diagnosis should be always based on the clinical sign symptom, how the patient present with the clinical sign and symptom, and the sample collection. Okay. So for the
yes,
sample
ma'am,
collection, you require.
sputum or bronchoalveolar.
Yeah, if the patient can cough, then you can directly collect the sputum. If not, you can do the procedure and collect the bronchoalveolar lavas and then do the staining. Okay, where you can see the yeast cells. And okay, and then you can do the immunofluorescent staining, and you can use the immunofluorescent dye and then see under the immunofluorescent microscope. Or PCR can also be done, or you can do the lung biopsy where you can see the eosinophil infiltrate, as well as there will be thickening of the alveolar septa. And Also, you can do with the help of blood, you can do the serodiagnosis for the detection of the antigen as well as the antibody. And you can also do the chest X-ray where you can see all the infiltrates. And there might be honeycomb appearance in the chest X-ray. Okay,
Yes.
if it is in the cases of severity. So for the diagnosis, you should always start with the clinical sign and symptom, how the patient is presented. Okay, and then do the sample collection and do all the
Stain.
diagnostic procedure. Okay. So in the cases of fungal, initially this parasite, okay, this was under the protozoa, but later it has been classified under the fungus. So this is one of the fungus that lead for the pneumonia. Can you name some other fungus that lead for pneumonia? That lead to pneumonia? What are the other fungal causative agent that causes pneumonia?
Yes, ma'am.
Mm.
Histoplasma capsulatum,
Mm.
Coccidioides immitis,
Mm.
Candida species, which leads to opportunistic infection.
Mm. So
Yes.
based on the dimorphic fungi as well as the opportunistic fungal disease. Okay, in the dimorphic there is a histoplasma. Okay, any other?
Coccidioides immitis,
Yeah, any other?
Blastomyces dermatiditis.
Why it is named as dimorphic?
It has two morphological form, that is mold form and yeast form.
So depending upon the temperature variation. Okay,
Yes,
in
ma'am.
the yeast form, in the temperature 37 degree, there will be the yeast form, whereas
Yes.
the mold forms are in the 25 degree C. Okay, and the opportunistic fungus like Candida, Cryptococcus, Aspergillus, they also lead for fungal pneumonia. Okay.
Yes, ma'am.
Okay, thank you. Okay, this much for today. Now I'd like to end my class. Okay, thank you.
Thank you, ma'am.